Welcome, everyone. Wait, everybody's present. Good. Welcome, everyone. My name is James Orbinski. I'm the director of the Doddle Institute for Global Health Research here at York University. And it is very much my pleasure to welcome my dear friend and colleague and guru in some ways, Ross Upshur, who is going to be speaking today to us on the concept of clinical public health and how and why this is important to a reconceptualization of how we approach global health. But before I do that, I just want to acknowledge the land that we are on. And I will encourage those people who are online to also acknowledge the physical land that they are on. Let me just say that today we are here at York University campus in Toronto, and York is situated on the traditional territorial area known as Takaranto, and we acknowledge its current treaty holders, which are the Mississaugas of the Credit First Nation. And I would also like to acknowledge this as the traditional territory of many other Indigenous nations, which include the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and of course the Métis. And this territory is governed or is subject to the Dish with One Spoon Wampum Belt Covenant, which is an agreement to peaceably share and actually care for the Great Lakes region that we are on. And so with that, I'd just like to give Ross, give you a little bit of detail about Ross, and then hopefully Ross will begin his presentation. And I will tell you, Ross, that this is an outstanding group of students.
Oh, I can tell already.
But no, they actually are.
Yeah.
Almost all here are PhDs. We've got one postdoc and one director of our humanitarian water engineering lab. But this cohort, just so you know, this is our first cohort of PhDs in our new global health PhD program. And one of the unique features of the program is that we seek out students who have prior professional experience. And so the students who come and join the program are students who have been appropriately trained intellectually, but also have some applied experience, and then come to the PhD program with a much more focused, much more confident approach to learning. And one of the things I've really loved over the last couple of months working with this group, people do have this kind of, they have this comfort with learning, and they know that they don't know, which is great. That's actually one of the most important things about learning. It's knowing what you don't know, or knowing that you don't know. Therefore, I'm going to learn. And it's I have to say, it's such a pleasure. They're very sharp, engaged, smart students, and I hope you'll find the same. So for your sake, I'll just tell you a little bit about Ross. Ross is currently the Dalhousie Chair at the University of Toronto in clinical public health. And he's also head of the division by the same name, clinical public health, at the Dalhousie School of Public Health at U of T. And he's a professor of public health in the Department of Family and Community Medicine. He's also associate director of the Collaborative Center for Climate, Health, and Sustainable Care, and an affiliate member of the Institute for the History and Philosophy of Science and Technology, and a member of the Joint Center for Bioethics. He serves internationally as co-chair of the WHO Ethics and Governance Working Group. He chairs the Canadian College of Family Physicians Ethics Committee, and is a special advisor for, I think, almost 25 years now.
A special advisor for 15 years. I was a working guy.
So he's currently special advisor to Médecins Sans Frontières, or Doctors Without Borders, on ethics and their research review board. But for 15 years prior, he was, I think you were chair at one point, weren't you?
Never chair.
Never chair. Thank God.
Yeah, thank God as well.
But deeply involved in helping MSF, WHO, and other international organizations that in some way engage in health, global health, humanitarianism, deeply involved in helping them understand and approach their work and their research with an appropriate ethical framework. So Ross is, is an extraordinary intellectual in the sense that his early training was in philosophy, not medicine, then trained in medicine, then trained in bioethics, and then led the Center for Bioethics at University of Toronto for many years. And one of the most, and he's also deeply, deeply committed to students and student learning. And I'm not sure that he didn't say anything about that, but I want to say something about it. I remember when he finished as director of the Center for Bioethics at the University of Toronto, we had a little reception for him. Of course, you have a cup of coffee with people, chats and so on. And one of the most enduring memories for me was that his students gave him a gift. And what was the gift? It was a two-volume collection of every single paper that he had co-published with his students. Right? So what that tells you is this person is deeply, deeply committed to the learning experience and to bringing people up through the required skill set in order to achieve the appropriate academic standard. And then the other thing I'll just tell you about Ross is that I've had a lot of years and experience with MSF at many different levels. And I can tell you that there are one of the most valuable thing in an organization like that is your reputation within the organization, not outside, within the organization. And Ross has a stellar reputation within MSF as a person who's practical, who's focused, who's intellectually rigorous, and yet fundamentally is committed to relief of suffering of people who are in very difficult circumstances, and fundamentally committed to bringing the best of what humanitarian assistance can bring to people in need. And so that's a glowing
Thank you.
intro, and I hope you live up to it.
Thank you.
So,
Well, with that, I'm going to go out and look for this person that
the hovering being that, that was
this person that you just described. So thank you for the invitation. I'm really thrilled and pleased to be here with you today. But before I start, I just want to take I know you're all great graduate students, and James has alluded to your practical background. Do we have any clinicians in the audience? Anybody trained in a health profession?
Yeah.
Okay.
Yes.
What do clinicians do?
Clinicians do a lot of bedside work. It's one of the key elements of clinical work, tending to patients.
So they say individual people with complaints, right? So as a practicing physician for 38 years, if somebody comes to me, my job is to figure out what their complaint is and create a diagnosis and management plan for them. So in one really fundamental sense, clinicians are involved and engaged with the care of individual patients. Would everybody agree is that how you understand what clinicians do? Yeah, did you want to jump in?
I think
Oh, come on. You've got something to say about clinical medicine, please.
So I'm a community physician, so we practice, we see patients regularly on day-to-day basis, plus we also do the public health work. So that's a combination.
A ringer in the audience, okay. So my second question was going to be, who here has a background of public health? Okay, somebody from public health want to tell me what public health does? What's public health?
Not a quiz, just
No, B, I want
just
you
a
to
conversation.
just toss out thoughts. You can't be that. Nobody can be wrong here.
I'm not.
Can you say something?
Just let him run, go ahead.
Focus more on prevention and
Okay,
treatment.
so-
We're looking at population.
Right. So it has a population focus and the cardinal three Ps, prevention, promotion, and health protection. So I'm a double agent. I'm a member of the College of Family Physicians and I've practiced as a family physician for longer than I care to think now. It's up in about 38 years. And I'm also a public health physician, a specialist in public health medicine. And in 2013, I was asked to create this division called Clinical Public Health. And what do you think the first response I got from my colleagues was? I'm going to tell a little narrative here about how to manage change and things. What do you think my colleagues thought? You're smiling, so you have an idea.
Can't be done.
Can't be done. What a crazy notion. Not only can't be done,
Doesn't make any sense.
doesn't, an oxymoron, shouldn't be done. In fact, it's dangerous to do this. So I took over the division. I'll tell you the story now. In 2013, we at that time had 80 faculty. We had 5 degree programs and the public health preventive medicine specialty Royal College training in public health and preventive medicine. That was when right after the Dalla Lana School became an independent faculty in its own right, separated out, born out of the loins of the Faculty of Medicine. And the first faculty meetings I went to, the body language was just awful because all of the medical officers of health who were involved in the public health, everybody was scowling at me like, are you here to destroy public health? And, the clinicians are going, my job is to see one person at a time. I don't have any obligation. Like, oh, I don't want anything to do with that. So I'm still in the job 10 years later, and we've grown from 80 to 220. In the faculty. So I'll explain a little bit about that evolution as we go through. So I'm going to draw on 2 papers that we've written, and this is the fun paper, Defining Clinical Public Health. The reason why we wrote this paper was because, remember I said there was initial hostility. They said, you know what, after about a year, we want to do a study. We want to do a study to prove that clinical public health shouldn't exist. Now, I'm the leader of this division. So you've got 2 choices. You can go like, I said, oh, that's a great idea. Let's do that. And I'll help you. Not only will I help you, I'll help you with the methodology. I'll submit it to the REB and we'll move this along because, if you think we shouldn't exist, then, I've got other things I can go and do. I don't want to lead a group of people who don't want to work together or don't believe that there's anything to this concept. And so you can see a large, very diverse range of faculty involved here, some physicians, some, doctoral, epidemiologists, a really interesting group of people. And one of the interesting things about convening that process in that study is it brought people into a form of discussion with each other. And as they discussed and worked through the idea, they actually changed their minds. And I'll show you that through a series of Venn diagrams very shortly. And so not only that, we've gone on to produce several other papers that outline this concept. So even if you're in hostile territory where you're facing principled disagreement, but you think you've got something that works, that actually makes sense, sometimes it's the onus is on you to better explain it, to better articulate it. Sometimes the onus is on the group you're working with. And I think James will support this. If you keep the discourse alive and you keep people speaking in a civil manner to each other, you get somewhere. So never give up. And I haven't yet, even though it's not made a whole lot of traction in Canada. So the questions I want to ask you is like, what are the elements of an ideal health system? And here are some examples of systems. So here's an electrical system. This is the solar system. This is the endocrine system. One thing that's interesting about systems is that parts and wholes connect. There's a kind of logic to it that you can figure out when something breaks down, where it broke down, because people like to talk about systems theories. And we hear all the time when we're talking in Canada, Ontario about our healthcare system. And what I argue, I'll tell you shortly, is that what we call a health system in Ontario, at least, or in most provinces in Canada, is an insult to a perfectly good word called system, because there's nothing systematic about it. Parts and whole don't connect. We have, insured services under a provincial health insurance scheme, but a funded insurance scheme does not a system make. So in your minds, what would make a health system work? What are the elements? Do you have any thoughts about what elements a health system ought to have? Let's say we were, do you remember that game Sim City where you got to build a city up? Let's think of a sim health system. You guys are all in charge now of creating a health system with all of your knowledge and lived experience and all of your scholarship. How would you configure that? Any immediate thoughts? Yeah.
I think that such a system should be characteristic of biospheric functioning. So all parts have to work.
Yes.
As in the biosphere, light makes light and so on and so forth from the sun downwards. Otherwise, there's
Going to first departure would be a good principle from planetary health, that understanding the deep interrelationship between human health and the ecosystems it inhabits is a necessary condition for sustainable good health. I like that. We'll put that in the agenda, but that's in there, right? So that's kind of like the primordial condition that we're going to work from. Okay, anything else?
Just ensuring that there's sufficient health care resourcing, just in terms of professionals.
Okay, and what sort of balance would you like in that? Again, you've got all the power here, so you're creating the system. So you want health professionals, but what kinds of health professionals do you want?
Ones that predominantly focus on ensuring reduction in healthcare burnout and optimizing population health. So
Okay.
primary care providers.
Okay, so you would start, so how many people, hands up, would like to base their system on some form of universal health coverage, primary care? So with the planetary health, now we're going to nest in primary health care. What else would you put in there as a fundamental building block?
Yeah. That's a reciprocity process where you're thinking about the waste emissions that are coming out of the healthcare system,
Great point.
mitigation of them.
And since-
Sorry, I'm not public health. I'm thinking about
that's an excellent point. So since we're in this space where we're creating an ideal system, this I think links to the very first principle that we would build our health system on sustainability principles. So that we would try to minimize our carbon footprint as we were building this out. So we've got two dimensions. These guys are right, they're good. So we got two dimensions of planetary health, sustainable care, primary health care, or primary care as a foundation. I'll give you two more building blocks because we could stay here all day and build this health system. Yeah.
So I'm also not a public health person. I'm trained in chemical engineering first.
Yeah.
So think about like a good feedback systems, the intercommunication between whatever they end up being, but a reciprocal feedback. So if there's a disruption to some part of the system, it doesn't happen in a silo and doesn't result in preventable escalation.
Right.
Some are not foreseeable, some are definitely foreseeable.
So
Operational.
you'd want to think about the living infrastructure, communications, redundancy, care pathways.
Yeah, it's a kind of idea that if you want to keep a system at steady state, but it's a dynamic system, you need to be constantly aware of the inputs in and the inputs out.
Right.
Because as those change, changes are gonna domino through the system. So in order to prevent the fuse number of dominoes from being knocked down, it needs to be not just autopsies after the fact, retrospective.
Well, that's what we like.
Done,
Yeah.
but like proactively saying this is happening here. How do we?
Okay. So a real system where part and whole connect in terms of information flow, understanding and tracking. I like that. I'll take that.
In Upshur?
Yeah.
I'm also not a public health person, but
Nobody has to apologize. It's not a very particularly popular career choice these days.
but some kind of information management or knowledge management system that is dynamic and is well understood by all of the different silos. So there's not a lot of jargon, technical language that can't be understood.
So you don't want silos in the system like we currently have, where different hospitals and their information systems can't communicate to each other, nor can community providers communicate with those systems.
Can I add one thing?
Yeah, absolutely. Anybody can add something.
Yeah, I just said, to me, the most important first priority is the purpose of the system.
Ah, yeah, what are we trying to do?
Yeah, and I would sort of frame it as our system should enable health and wellness and should be able to remediate, respond, whatever language you want to use, to morbidity and mortality, so that again, health and wellness is enabled.
Okay. I like
So,
that.
and it has to be effective,
Yes.
not
you need
just
a-
words. It's
You need
gotta
a
work.
vision, you need goals, you need a T-lots, so to speak, and then
Exactly.
drive your services to that T-lots. It's interesting, nobody mentioned, well, I'd really like to see a tertiary care academic health science center with excellent transplantation, xenotransplantation, CAR T cell therapy, like nobody bought into the high end where actually we spend disproportionate amount of our money. Just a warm up. So and it's an ancient problem. So this is the bust of Herodotus, who's variously known as the father of history or the father of lies, depending on, and he wrote a book called Histories, which is a super entertaining book. Full disclosure, I started as a philosopher in a classical studies double major. So I read a lot of ancient Greek stuff. And so Herodotus went around what was then the known ancient world and just collected stories, narratives, and he took them at face value and he wrote them down. And when he was in Babylon, he made this observation. He said, next in ingenuity to the marriage custom is their treatment of disease. And I won't get into their marriage custom. It has to do with lotteries. They have no doctors. And if you follow the history of, primary health care, the idea of having a health system with no doctors is considered to be a desirable thing. So they were good back in those days. But bring their invalids out into the street where anyone who comes along offers the sufferer advice on his complaint, either from personal experience or observation of similar complaints in others. Nobody is allowed to pass sick persons in silence, but everyone must ask them what is the matter. The perfect model of community engaged primary health care. Everybody has a stake in it. Everybody's concerned for their citizenry. This wouldn't work very well from where I come from in Winnipeg in February. The last thing you want to do is leave your beloved one on the street and wait for people to come by and offer up some advice on how to manage it. So we've been thinking about how best to manage health and illness for a very long time. So it is a long conversation. If you're interested in the history of public health, this book by Dorothy Porter is Excellent Health Civilization in the State. And she makes this observation that debates surrounding healthcare and public health reform continue throughout the Western and Eastern European communities. In fact, they continue globally. It's a very active area of discussion. Here, as within industrialized and industrialized societies throughout the world, the pressures of demographic transformations, epidemiological transitions, force policymakers, professionals, and the public to participate in the debate surrounding the health of populations. Now, how these are going to play out now in the 21st century will depend, as it has always done, on national histories and cultures, international development, and political will. And as we know from what we've been hearing from the results of last week's election, we could see a very big sea change in how public health is regarded south of the border. In fact, if you take some of what is being asserted seriously, it seems like the late 16th, early 17th century is the destination that is being preferred. Sorry, I will try not to make egregious political comments. So the pandemic gave us a really important time to reflect. In fact, if I were to ask for anything, and I wouldn't ask for it willingly, having worked on every major outbreak from SARS-1 back in 2003, H1N1 in 2009, Ebola, Zika, Mpox, and of course, significant engagement during COVID for the last 4 years, which is not over. But it made the case for why clinical public health is important. And I don't know, does everybody know who Atul Gawande is? So he's a surgeon by training. He writes about health and health policy in the New Yorker. He's written several influential books, one called The Checklist Manifesto, another book on sort of like end of life. So basically amongst the health intelligentsia, particularly in the US, when Atul Gawande speaks, people listen, even if what he's saying is something that people in academia have been saying for some time. But he's now moved, and interesting career. You get interesting time. So he went from being a surgeon, an academic surgeon, to now heading up work to revive and build and expand primary healthcare globally. He's in the global health space. And in an article in the New Yorker, where he was observing, I mean, the point of the article is, why is it that, all of the health outcomes in Costa Rica are better than in the US? What is it that they do in Costa Rica that they don't do in the US? And he says, as the pandemic ebbs, countries will be assessing what went wrong with their public health systems. And here is in bold, a fundamental failure has been the separation of public health from healthcare delivery systems. I almost cried when I read that. Thank you, Atul, because I know when Atul speaks, people pay attention, but this is precisely on point. Getting that right across the globe could present our greatest opportunity to secure longer and better lives. And that's, to me, what represents the high overarching goal of clinical public health. So historically, they've come together, they've fallen apart, they've competed with each other, but when they work in harmony and synergy, then we can actually, if we design it that way, we can really make some benefits. So let's start with a definition. So this group of rebel faculty members who started out with the idea of, throwing out the leader and ending the empire, so to speak. So we define clinical public health as the structured and systematic collaboration of clinical and public health professionals in pursuit of common health goals. We argue that adopting, promoting, and formalizing the concept of clinical public health can facilitate the necessary interdisciplinary collaboration to improve health for all. So we think that, continuing to operate as we've been operating will not get us there. And, it's a long pathway to get there, but at least I've pursued it. So these were the famous Venn diagrams. So the study we did was at Delphi. So, and before we had this, I used to walk around like this. So this is clinical and this is public health. How do you think they interrelate? And a really fun thing I do at the Dalla School of Public Health, we have an outreach program to high school kids out in Scarborough, and they were fabulous. They got it right from the beginning. So yeah, that makes sense. If public health is about promotion and prevention and protection, and clinical medicine also has health promotion, they should be like this, shouldn't they? I went, oh, bless you. Can you come and I was going to bring them to Queen's Park to meet the premier. So this is where we landed, is that clinical practice and public health. So the misunderstanding, and I think I didn't do enough at the beginning to assuage the fears of my colleagues in either sector, was that I'm not here to tell everybody that they should be there or everybody who's there that they should be here. What I'm saying is that there is a healthy overlap of the sets of activities where stronger collaboration could make a massive difference for population health. So this was the final model that we ended on, that should be the relationship. It's the intersection and overlap between where clinical health and public health and clinical practice intersect. But we had some creativity. Well, public health and preventive medicine are separate things. In the US, there's a board for preventive medicine. Here in Canada, we teach them together in the Royal College. And so that maybe we could separate out those two. But everybody said, no, it's just good to, we don't want to have clinical, preventive, and public health. So we dropped that. Then there was this notion that, hey, clinical public health could take over the world and everything else could be subordinate to it, right? So all the other sectors were, so the basis of health systems would be in clinical public health. Then were those who said, well, really clinical public health is a subset of public health. And of course, it went the other way as well. Clinical public health is a subset of clinical practice. And this is where we started. And there's the number. But I'd go there and my medical officer friends say, clinical and public health are two completely different worlds. They don't intersect in any way. They have different missions. You know, our job is to work at the our patients are the population. We don't see, and the clinicians go, yes, it's our job to see one patient at a time. And we go, well, you know what, so this one lost. And this is where we started. And I'm going to use laser pointers. Got it. This is where we ended. So let's explore this in a little bit more detail. So here's a graphic that my colleague Jennifer Gibson and I put together. So it's a matrix that says, you've got patients and individuals, and down here, this is the healthcare. This is where primary care is. This is, we're not asking medical officers to come in and start diagnosing disease. So there's a realm of activities that are actually purely in the clinical realm. And then there's a set of activities that are largely within the public health realm. So for example, health protection will always be within the public health realm, largely because it's a legislated function. We call them medical officers because they have policing powers, which they need in order to, curtail and contain threats to populations, either through epidemic disease, communicable disease, toxic exposures, et cetera, et cetera. If they don't have that power, they can't take the necessary protective measures to prevent morbidity and mortality. But in the middle are a whole set of things where you can actually collaborate together. And remember, we started with the 3 Ps of public health. Health promotion is something that most clinicians are trained in. Prevention can be clinical or it can be primordial based on intersectoral things, but clinicians play an important role in prevention. And in fact, early on, so one of the framing thinkers of our modern conceptions of public population and public health, Jeffrey Rose, said that every clinical encounter, he wrote this book on strategies of preventive medicine, talk about population health, but every clinical encounter is you can get at the cause, but you can also ask about the cause of causes. It's an opportunity to ask not just what can I do for you now, but how can I prevent what happened to you from happening to others? So there's a preventive moment in every clinical encounter that often gets forgotten about. But you can see here, health services planning by population characteristics and needs. And as we move into the construction of universal health coverage and primary healthcare models, or if we look at primary care reform in our own country, now we've got, team-based models of care that are capitated, right? They've got a roster of patients. So now, in fact, clinicians are, yes, they go into the clinic and they see a patient at a time. But when I lecture to the medical students about this, I can say, you could have a day in the clinic where you saw 3 type 2 diabetics and you did all of their, evidence-based guidelines. You can check the boxes and you can go home and say, I've done a good job. And I say, no, your job is not done, because now you have a defined patient population. You need to ask yourself questions about all of the type 2 diabetics in your practice. And you need to look into your roster and you need to see who are those with type 2 diabetes that haven't come for their regular maintenance and preventive medicine and health promotion visits. And when you scratch the surface, as we don't have time to go into all this today, usually the barriers are rooted in structural barriers and the social determinants. And there's also a role, as my colleague Andrew Pinto at St. Mike's, who's developed what's called the Upstream Lab, which is working on how primary care can engage in, intervene in effectively in social determinants like income support, housing support, many of the structural barriers. Yes.
I was just going to say, so part of the undergraduate global health program, so at Angela Pinto's Upstream Lab actually collaborated with them.
Good.
So actually, that was my practicum, and I really appreciated that entire experience. So
Yes.
their specific project was on income security health promotion.
Yep.
And then being able to sit down with the patients and prescribe something outside of obviously the medical component of just family care, just provision was mind-boggling, not mind-boggling, but just outstanding to witness.
Yeah, no, that's so just full proud to hear that because he's one of my former students. And
So he survived you.
He survived me. Now he's my teacher, right? He's doing amazing work. But that is actually what the Upstream Lab does, and he's a member of our division, is actually advancing. He doesn't call it clinical public health, but when we were out trying to persuade before the Ford administration came in and created Ontario health teams, we've been really engaged with the local health integration networks, and we have them this close. It's close, but yeah.
So I have one question on this slide. Your previous slide shows an overlap, a Venn diagram overlap.
Yeah.
And are you suggesting that the Venn diagram overlap here, the content of each of the three different colored spaces, that this somehow is consistent with the content that should be present in clinical public health overlap?
Yeah, so, but you can configure this. When often when I run sort of workshops on this, I get an empty one of these and say, fill it in.
Okay.
Fill it in.
Okay.
These are all just for example.
Yeah, because I quibble with some of them, but never.
Yeah, of course you can quibble. That's the whole fun of it. If you can't quibble, like there's no point. So we also argued, and this was where we were looking at this greater integration, where we thought there were 4 synergies, at least for Canadian application, where a closer relationship, and we did a scoping review. So coordinating healthcare services. So oftentimes when we're looking at a population health needs assessment, public health unit will go and do it. Like in Ontario, it's run municipally, but they don't talk to the clinical community. They don't harness the data, for example, that can be collected in primary care to get sort of more nuanced, granular local epidemiology. This is important, and I'll come to this later because I think this is really the most important connection, is what we call the bifocal vision. That each patient encounter you have, we understand that's what clinicians do, is you need to sort of step back and integrate that within the population. Similarly, if you're a population-based or a public health practitioner, you need to be able to, go down a level. You need to adjust the lenses that you're analyzing. So it's a good way to identify and address community problems. I mean, I work and I'm a professor in the Department of Family and Community Medicine, and I keep asking, well, like, where's the community? We're training people who go out and work like regular doctors in an office seeing patients all day. Where's their engagement with the community? How is it that clinicians can serve their community needs in a better way? Strengthening health promotion, and I would say a certain amount health protection. This might be more important now in the context of increased distrust in public health, where the clinical community can, I think, help to assure their communities on the importance of public health, and addressing inequities in care and outcomes if you have the appropriate access to data that actually demonstrates what's going on in your community. So the pandemic actually, again, I'll come back to that because I think it's our biggest selling point. It shows how collaboration between public health, healthcare, and other sectors can lead to more coordinated responses that serve, protect health, and save lives. So 3 things in Ontario, they actually started sharing data. Public Health Ontario and health and clinicians started to actually share data on cases and spread across the province, and they almost got it in real time. So I think somebody was mentioning, wouldn't it be nice if we wasted so much? We waste a lot of information in healthcare. It's stunning. Every patient encounter is an opportunity to collect information on what's happening in the community and to aggregate it up to look for patterns, to detect early signals, but most of it is wasted. We did actually combine clinical and health system data, and that allowed us to proactively plan for and respond to changing health case counts. So, the experience in Ontario with COVID was not uniform. Right, even within the GTA was not uniform. There were hot spots where transmission rates were much higher, but people stepped back, worked together, were able to find the hot spots, were able to mobilize and move resources. And the most impressive, even though I hate to admit it, was how critical care managed beds. So there was a big concern that we were going to overwhelm the capacity for beds in critical care. And one of the thankless tasks that I always get involved in is, can you help us come up with a framework for setting priorities over who's going to get an ICU bed and who is not? If you want to make friends, that's a really good committee to serve on. The second popular one would be that I was on early on was when the COVID vaccines were first available in early 2021, who's going to get the vaccines first? But if you combine your clinical and health systems data, I think it allowed us, one, we actually were able to manage critical care beds without overcapacity in any center, even though some came close, they opened up beds. So somebody from Hamilton might end up in Ottawa, but they got there, they got an ICU bed, and we never exceeded capacity. And a lot of that was because health systems, public health people, and clinicians were working together to solve it. And then this notion of collaboration between public health units, municipalities, and primary care was actually a very successful model for creating the kind of mass vaccination programs that were required to, early on, there was a kind of dribble of vaccines, then all of a sudden there was an abundance, or there was a huge demand. How are you going to vaccinate, millions of Ontarians in the fastest way possible? That took collaboration and cooperation between public health units, because they're the ones that are responsible for understanding the vaccination status, municipalities, because they gave up things like arenas and things for us to do. And then the primary care nurses and physicians came in and delivered the vaccine. And everybody thought, that's kind of cool. And then, the nice thing about this, again, when you get people working together, they start to understand each other. And they start to see that they're actually not the enemy. They're actually our colleagues and collaborators. And I know I've got far too much text on these slides, and I apologize for it. But the Lancet Commission picked up on this in big time. They came up when they did, what did we learn for the future from the COVID-19 pandemic? And they said, among high-income countries, those with strong and resilient national health systems, including public health systems that complement clinical health care, fared better, right? Reiterating that point that Atul Gawande meant. And therefore, like I asked you, when you're going to build, if you had the possibility of building up a health system de novo, you should strengthen health systems on the foundation of public health and universal health coverage. But it should also be based, that healthcare systems should be based and centered around primary healthcare. So it's not just Upshur anymore saying, no, I think there's something to this intersection between public health and health systems. So, and here's what they say: strong public health systems should have health education, health promotion, disease prevention, and emergency preparedness. All of that can be done in parallel and in cooperation with health systems based on universal health coverage centered on primary health care. So if you were, in charge of a health system, if you were given, unlimited power to redesign and reconfigure a healthcare or a health system, I don't say a healthcare system, health system being all the resources of a society brought to bear on improving and optimizing the health of your population, you could do no better than building it on a basis of public health and primary health care with some form of universal health care access. And that's not just the opinion of the Lancet Commission and Gawande. If you unpack the voluminous empirical literature that is completely reinforced. So in the primary care sector, all the work by Barbara Starfield on how, the 4 C's of primary care: continuity, coordination, first point of contact. There's a 4th C of, I'm forgetting it now, but the empirical evidence shows that systems that are based strongly in those principles have the best health outcomes. And, Atul Gawande, who started as a surgeon and then went in and started looking at health systems, it's really cool. When you've got these two things connected, you've got better, take a population health metric. And those systems that have this kind of coordination have better outcomes than anywhere else. And
Can I ask you a question?
Yeah, sure. Yeah, please stop at any time because I just ramble on.
How did we get to the point where what, at least to me, seems intuitively obvious?
Yes.
Or even not even intuitively obvious, but self-evident.
Blindingly so.
It's self-evident. It's so self-evident. You don't have to. It's not even a thought.
Yeah.
Right. Just, this is the way the world works. How do we get to the point where we had such siloification
Yeah.
of our approach to healthcare.
Yeah.
That suddenly nothing is in touch with anything.
Yes.
And that the revelation of a clinical public health approach actually requires not just a intuitive understanding, but a kind of a massaging, which is what I'm hearing a lot of you talk
Or a
about.
global catastrophe.
Yeah, or a
Like
global catastrophe.
pandemic. Yeah.
So for example, was there ever a time in history, the history of medicine and the history of health, where these two were one and the same?
They have come and they have parted.
Yes,
And
this is
I teach a
Can
whole
you
course
talk
on
about
that.
that? Just
Yeah.
give
I'll
people-
show you, my last slide speaks to that point. Okay. Just about done. No, I've probably talked to that. But not everybody agrees. So this is again, there was a commissioned editorial in the Journal of Healthcare Affairs called "Is Public Health Ready to Participate in the Transformation of the Healthcare System?" And I was one of the co-editors on this with my boss now, who wasn't my boss then. And we had comments. Andrew put a paper in here. Arlene King was then the Chief Medical Officer of Health. So these are all kind of very prominent leaders in public health and clinical care. And the lead article by Millar et al. Came to this conclusion. Well, we don't want to. Nonetheless, across jurisdictions in Canada this time, although they perhaps are supportive of the greater concept of greater collaboration, public health professionals are largely restrained by numerous barriers, past history, inadequate finances, resources, and training, and are unwilling or unprepared to lead or participate in system change, which I found to be a devastating. I think we've moved on from there, but it's the same thing you hear from CEOs of major hospitals when you talk to them about this. Yeah, that's a good idea, but we've got our mission, and we've got to advance the frontiers of genomics and transplantation. So even though it makes intuitive good sense, the enemy is us, so to speak. Lots of opportunities. So here, this is the work that Andrew Pinto is doing. I'm going to talk about these 2 points in particular. I won't talk too much about healthy pairing. So the other idea here is this notion of learning health systems. And I think it speaks back to the point raised earlier about how do you manage things as a system in a complex dynamic environment. The interesting thing about these original views of learning health systems were all based in healthcare. They didn't include public health. So we wrote a white paper on how to, why public health should be part of these learning health systems. But the idea here is that you have you don't throw away information in your health system. You have this kind of virtuous circle of knowledge to change knowledge to practice, practice to data, data to knowledge, critical reflection based on core values with ideas of outcomes. And so the origins of a learning health system stem from the recognition of the need to better harness data produced, stored in various sectors of the health system. But I would say it's more than just data. It's actually knowledge that's generated. There's a lot of craft knowledge in healthcare that gets missed out on. The need to integrate this more rapidly into practices and organizations, and to desire to drive this improvement in quality and outcome. And there's another initiative, again, coming out of the World Health Organization called the Clinical Trials Initiative. They passed a resolution at the 2023 World Health Assembly. A lot of their focus is saying, we learned in COVID that platform adaptive trials are really good for generating reliable knowledge. But all of the platform adaptive trials were carried out in intensive care units, so the famous recovery trial. And so when I was in Geneva in June, there was a small cadre of us who formed a primary healthcare and said, if you want to move the dial on population health, you need to embed this clinical trial capacity into these universal healthcare constructs in order to actually generate knowledge that actually matters for a wider number. Like I'm really happy that less people died in the ICU, but the number of people who get into an ICU relative to the population at large is very small. We need to take that opportunity and embed it into a learning health system. So you can see I'm still not out of crazy ideas. The other thing that really motivated me was this notion, so health professionals for a new century transforming education. This was meant to be the 21st century Flexner report on how to transform health professions education. And they say there's a vision for all health professionals in all countries should be educated to mobilize knowledge and engage in critical reasoning and ethical conduct. So you're all going to be philosophers, right? So that they are competent to participate in patient and population health-centered system. That bifocal vision, and we need to completely radically transform not just our dysfunctional interactions with each other, but health professions education, undergraduate, postgraduate, graduate education. We're not there yet. And this is where I'll end. So this has been a problem, and this links back to the Porter quotation I had earlier. So when I was doing this work, I stumbled. So everybody knows in 1964 in Canada, the Hall report came out, which set the blueprint for what eventually became the publicly funded healthcare system in Canada that the Pearson government brought in. But at the same time, they also commissioned a report on health professions. Like what is, that I think the question was like, what are the types of health professionals we're going to need moving forward? So they did this big report. And one of the chapters was on public health. And it said, several briefs presented to the Royal Commission by public health specialists have been critical of the lack of interest on the part of practicing clinicians in the programs of community health and lack of or inadequate practice of personal preventive medicine by these physicians, right? So the public health, they were called hygiene specialists. They were wrapping the knuckles of their clinical public health. And there's little doubt that most of these criticisms are valued, but it's equally true and has not been so clearly stated that schools of hygiene have made little effort to train public health officers to become close collaborators of the practicing physicians in their communities rather than their critics. So that's like 60 years ago, plus ça change. And our goal in the Division of Clinical Public Health is to actually try to, remedy that situation. So that's my final slide. I hope this has been of some interest and value. I'm open to take questions, and I'm grateful for your time and attention.
Thank you. So I'll just, in one sec, Alex, just going to ask Ross to just talk a little bit about the origin, if you will, of the split between public health and clinical medicine.
Yeah.
And my interpretation is that by really from the 16th century right up until around 1850, 60.
Yeah.
The idea that there was, the physician was a person who treated disease, but also looked to the sources of that disease, the causes and conditions that created that, and tried to address those. And the best example is Snow, of course, with the discovery of cholera. Right. So Snow was a clinician, but now we look back and we call him an epidemiologist, the father of it.
Even though he was also an early anesthetist.
And he was an anesthetist. Right? So this is exactly my point. So we often look at history with the lens that we have with our glasses of today, and we impose on the past today's conceptions of how we think we should actually go toward the future. So we can actually misunderstand the past.
Yeah.
And so when we think of a person like Snow, who discovered cholera, right? And he's the guy that famously discovered the source of the cholera epidemic in London, and actually chained or closed the water pump in the little neighborhood where people were getting their water and were subsequently getting cholera. So the cholera, the source was cholera. Now he did that because he was seeing all these people who were dying, sick with diarrhea, and many of them dying. And he was trying to figure out something big is happening beyond my clinical experience, right, with this person. So I'm thinking about the causes and conditions of these individual experiences. So that was normal, right? That was how things were done. Now, subsequently, there was a change. right? And so subsequently, I would argue, and I just love your reaction to this, I would argue that, the separation of clinical medicine, the clinical touching of a human being who's suffering in some way, or asks you for a specific individual, intervention, the separation of that act from consideration of the causes and conditions that create either health, wellness, or disease. That was actually motivated by money, and it happened in the United States.
Yeah.
And the idea, and it was very clear that the people who could see patients could make money. It would be paid, right? And the richer the patient, the more you'd be paid. Right? And the people who were concerned about causes and conditions and like what's driving this, there's no money in that. There's like, who's going to pay you? Right? There's no public health department. There's no, who's gonna, good. I'm just going to focus on the people who can pay. So what happened was, over time, the recognition from a public policy perspective that a public health perspective was really important. This then became funded by the public, by the state, right? And the clinical aspects of care became remained very much in the private domain in the United States. As it still is, very much in private domain. So, and then that overlaid with the scientific revolution, the kind of post-Enlightenment revolution, and this sort of focus on reductionism, and this focus on hyper-reductionism, really led to, first of all, a focus within the clinical practice on, again, an even more kind of deliberate intensity to individual patient care. And then even in public health suddenly turned into risk factor analysis for specific diseases. And that became the essence of public health for 50, 70 years.
Yeah.
That became the driving ethos of public. And the idea that there are broader causes and conditions that influence and shape the social determinants of health, which account for at least 70 to 80% of all causality, as we know, right? That was an idea that just kind of evaporated into the ether. And only from, I am open to being corrected, but only from I believe, roughly around 1981, did that start to again take some hold. The societal determinants of health as something that public health should be concerned about. And it's now achieved an important place in the kind of lexicon of thinking in public health. But it's now, so there's a kind of, this late 19th century moment where there was convergence between, not even convergence, sameness. It wasn't even separate. They couldn't convert, they couldn't be, they were not separate, therefore they can't converge. They were the same, clinical and public health. That then split. And now we are coming, it's the third decade of the 21st century, and clinical public health as a uniting concept it's now bringing those disciplines or those ways of seeing back together again.
Yeah, I think that's
so could you just sort of
so two things.
Give us your historic perspective on that?
Deeper historical, if you go back again to the ancients, in the Hippocratean corpus, there's a text called Airs, Waters, and Peoples, where Hippocrates says you can understand a lot about the illness in a population by understanding the climate and the water and where the winds come from. And that kind of percolated through. But really things start to change, I would say, in the 19th century and in the mid-19th century in particular. So public health as a thing became official in the UK when Edwin Chadwick, who was the secretary of Jeremy Bentham, who was the founder of the doctrine of utilitarianism, who was a very much an applied social reformer, passed the first Public Health Act that set up the structure for medical officers and for health units with a real focus on mains and drains. At the same time, there was the birth in the later in the 19th century of the social medicine tradition, with Rudolf Virchow, which was quite influential in Europe and remains influential in South and Central America in particular. So, prominent figures in that are, people like Che Guevara, Salvador Allende, where integrating the social and the medical are hand in glove. And political, absolutely. So that tradition still, so when I talk to my Latin American colleagues, they yawn and say, yeah, we've had this for a long time. I say, yeah, no, but I'm working with a different group. The other area is in South Africa, where community-oriented primary healthcare originated with the Sussers in the 1960s and 70s, where they started to, build community health centers that were actually connected to sanitation, water, environmental conditions. So there are a lot of changing things, but in North America in particular, I'll go back to Flexner. So the American Medical Association came into being in 1867 with a very clear mandate, as did the Canadian Medical Association when it came into being in 1868. So it's hard to go back and remember that physicians weren't the only healers. There were osteopaths, there were homeopaths. Actually, homeopathy is alive and well in Switzerland, right? In Germany, right? Yeah. And so they organized to actually basically marginalize all those other professions. And then when Flexner wrote his famous report, and I read it quite carefully because, the question you asked was like, how did we separate? Part of the separation starts there with the idea that medicine was rooted exclusively in biomedicine, and that the path to training health professionals came through university education in the basic sciences. And then, the Oslerian model of, you get your undergraduate basic sciences, and then you start to see patients, and of course, the birth and dawn of specialism aided by greater technologies. But the interesting thing when I reread the Flexner report was he just assumed that medicine served a public health good.
Yeah, see, that's
right. And so without it being explicitly argued for, it was eclipsed and disappeared. And that last slide I showed just represents what happened basically from the Flexner report in the early 19th century to the mid-century 1960s. And things have not improved, at least in Canada and the US, in terms of that convergence. So, and I'm not confident that we actually learned from COVID, because I've seen nothing in health system reform in Canada that moves us closer to this convergence. So, but when I talk to my colleagues, I always like going to Geneva because you're running people from all over the world. They say, yeah, tell me more about this. We're thinking of healthcare reform. So I've had conversations with people from Ghana, South Africa, lots of places. And then the one encouraging thing is there's 3 new medical schools that are being started, 2 here at York, I believe, one at Metropolitan and one at Simon Fraser. And they've all reached out to say, how can we integrate clinical public health into our undergraduate curriculum? So it might be an even longer path to since then, I think.
The sources of change rarely come from within a system.
Yeah.
And the sources of actors and elements within a system will resist. Right? By definition, they will resist unless there are imperatives to not resist. And right now, there are no imperatives.
Yeah.
And then so what are the sources of change? They usually almost inevitably come from outside of an existing vested infrastructure. So I'm not surprised that your experience is bearing out.
I got sore arms, right? I've been pushing a rock up a hill.
Yeah. Thoughts, comments? Alex, you had a comment.
Yes, I was just wondering, as I was kind of listening to you talk about how they're trying to integrate more shared learnings and shared data, that these appointments as data collection, not only for the individual, but for the surrounding population and the community. I was wondering what kind of privacy concerns are emerging in this area. I went to law school, so I was just kind of wondering, how are they dealing with
Great
that?
question. One of my favorite topics, something I've done an awful lot of work in over the years. So there's ways of managing concerns about privacy. We already have legislation in place. We have the Health Information Protection Act. In Ontario, it's one of the wiser pieces of legislation that I've seen, because back then, so early in my career, I was affiliated with the ICES, the Institute for Clinical Evaluative Sciences, which is a health services research institute. We get all the health data from the province of Ontario. We use it to, we anonymize it, encrypt it, and it allows us to do, massive linked studies on what's happening in the population of Ontario. Early in its days, it was under threat. Is in the late 90s, many jurisdictions had concerns about health information privacy, and we're making arguments about you need every person's individual first-person consent to even think about using it in a de-identified or aggregated form. So I wrote a paper in the Canadian Medical Association Journal, basically arguing that this would be a huge mistake. We would be effectively blinding ourselves. The US went that way. So Rochester County, where the Mayo Clinic is, had some of the most superb longitudinal data on every person in that county. And it was a rich source. And when they had to move to an individual first-person consent model to actually collect and use that data, they lost about 6% of their population. And not unsurprisingly, the 6% of the population they lost were those who were most disadvantaged, most at risk. Same thing in the UK, they lost their cancer registry. Canada, fortunately, or Ontario stopped and said, maybe we can think of a governance strategy. And that's where they came up with these notions of, data guardians. And I would still like to see, so we have an office of, information privacy. I would like to see, here's my perfect world, is we would have a separate health information governance structure that had community membership in it, and it would govern the data. If people feel like there's a lot of contradictory views about what people want with their data, that's really subject to framing bias. And I pointed that out in the paper. If you ask, should healthcare, should researchers have access to my data? They'll say no. Would you be willing to allow your data to be used for health improvement? Oh, of course I would, So I think there are governance structures. And the one thing I'll say about ICES, it's been in business now since the early 90s. I think I was the second graduate student there. They have never had a serious violation of their policies. And if you violate their policies, there is serious consequences, right? You are not going to be, if you ever violated it, nobody would touch or hire you again.
Yeah, you're done.
You're done. So we've got an excellent, and one of the things I did in writing that paper was reviewed, like there's all of these, some of them are kind of urban myths about, people's health information being shared, but inevitably it's somebody with an axe to grind. It's not a researcher, it's not an operator, it's somebody who went out of their way to find out health information about somebody and release it. So rogue actors are not the way that you build a system. Good governance and sound, and we've got the techniques to do it. Sound data management and governance with access policies, with security, is a way that we can actually move towards this.
So we're over time. Are you able?
I'm sticking around if you want, if you'll have me.
Absolutely. So I'd like to just close the seminar, or the first part of the seminar, the graduate seminar. And thank everybody for joining, and most especially those online, and thank Ross for a wonderful presentation. You've really just given us a great introduction and a great set of challenges that are embedded in each of the elements of the concept. So thanks so much for that, Ross. That was fantastic.